Welcome to the Care for Nurses podcast. Here we feature different guests and topics to help inspire, educate, and support nurses. Today we're talking about addiction medicine with Dr. Jason Kirby, discussing new advances in the field, what self-care looks like in real life, how to talk about addiction with patients, and special addiction certifications for nurses.
First of all, thank you so much for doing this. I really appreciate you taking the time to be on here and talk with us. One of the questions that I kind of want to jump right into, given our time constraints, is what are some things in addiction medicine right now that is at the forefront? Maybe it's some new thoughts coming out. Just kind of curious where things are at in addiction medicine in the moment, because I know it's an ever evolving, right, field.
Yeah, no, that's a great question. Addiction medicine has been an interesting journey the past 10 years. I remember when I first started, it wasn't really a very organized subspecialty yet. Everyone was kind of doing their own thing. States had their own licensure and procedures. New York were doing things differently than Texas and vice versa. So the standards of care were very difficult to really, iron down. But it's been an amazing transformation the past 10 years. Having board certification for physicians adopted by the American Board of Preventive Medicine has created this very standardized pathway. So everyone does the same things. To kind of put it from medical terms, let's say that you were having, a chest pain. That's a great example. If you're having chest pain and you go to a hospital, to an emergency room, anywhere in this country, I guarantee you they would be doing very similar things because it is just a very standardized approach to trying to figure out where that chest pain is coming from. Well, for the first time ever now, with some of these guidelines that are being published, like the treatment of opioid use disorder, the treatment of stimulant use disorder, the treatment of alcohol withdrawal. We're starting to get on a similar playing field in addiction medicine. And that's the hope of the specialty. Whether you go to a hospital in Texas or you go to a hospital in New York, you'll be treated the exact same way, regardless of any stigma, which is something we're continuing to battle, unfortunately. But where I would see the profession now that I think is just really cool is, and I say this all the time. In fact, I just had a conversation about an hour ago with one of my nurse practitioners that I supervise. There hasn't been a lot of positive things that have come out of the opioid epidemic since the 90s. But one of the things I would argue that has been very positive is the amount of money and attention thrown into addiction research and what works, what doesn't. And so that's been really cool. The last 10 years, we've seen an explosion of evidence-based medicine come out and guidelines come out in addiction medicine, and it's been very, very helpful. We're hopeful that that will continue. I think probably the biggest thing I'm currently interested in from say a medication standpoint are the GLP-1s, the medications like Ozempic and Mounjaro that you take for weight loss and for diabetes. There's been some evidence that they can potentially help with this dopaminergic response, the brain's reward pathway, and turning that down a little bit. And we've seen some good responses so far with patients who have taken GLP-1s with alcohol use, and we're starting to look at other substances as well. So I think that that'll be really cool. I'd love to see some additional resources come out for physicians, providers just in general in addiction medicine, because we just don't have that many tools in the tool belt. Psychotherapies, some limited medications have kind of been what we've been using the past 50 years. So some additional tools would be cool. So I'm really excited about that possibility. And, I've linked up with a few academic institutions, and I know I've worked with some researchers in trying to get my patients on panels so they can be included in some of these studies. So I'm excited about the future.
Oh man, that's wonderful. Thank you so much for that. It's a nice little overview as well. So I appreciate you taking the time to explain that. I would be curious. Any information that you have, please share it. We'd love to be able to share that as well and dive deep into it. Another question that we had was specific around nurses or healthcare providers in general.
Mhm.
Um, how addiction can affect a healthcare provider personally. It can
Mhm.
affect them as the provider themselves dealing with their patients, and
Yeah.
also coworkers, right? So thinking about probably those top three main ways that you interact or that a healthcare provider can interact with the addiction world. What are some key points you may have? And I know they may vary depending on how you interact with them, but what are some thoughts that you might have for a practitioner and how to identify or address addiction as they may see it in those different viewpoints?
Well, I would say in the context of, so, a nurse working in a setting, um, ask the question, right? I think we have a lot of screening tools now to identify problematic substance use. Um, the CAGE questionnaire, the audit, the DATS, or I'm sorry, DAST, the DAST. All of those are very good screening tools. But just talking to patients and getting an idea of, hey, you know, what are your thoughts surrounding this, right? Alcohol in this country will always be king. We as a society have drank alcohol since the founding of this country, and I would probably argue we will continue to drink alcohol no matter what evidence comes out. What we know is about 10% of folks, when they drink alcohol, will develop compulsive behaviors that are consistent with an alcohol use disorder. And when you look at residential programs, I don't like to say the word rehab. I'm very anti-stigma, but when you look at residential programs, still about 60% of patients who go to a residential program are still alcohol use disorder. Although we talk about opioids a lot, rightfully so, alcohol is still king. Still kills 88,000 Americans a year. And so it is a conversation we all still need to have. Yeah, just asking the question. I think the nursing protocols that I've been experienced to are, they do really well. Nursing assessments do a really good job at helping to identify problematic use patterns in patients. And that can give at least a starting point to try to figure out, is this something that needs to be addressed or is this not? Now, probably on the other end of your question, there are some nurses. Nurses are people, doctors are people, um, like everybody else. And again, one of the things that we've seen in this field is that um, we are just as likely, if not more likely, to develop use disorders ourselves in healthcare. And so I'm a very big proponent for physicians' health and nursing health. I know a lot of programs throughout the country that deal with physician health programs, nursing health programs, to try to identify nurses and physicians who do have a compulsive behavior towards substances, and trying to get them to identify that, get them into treatment so they can get back to work and lead a functional life. So yeah, two different things, but both are very, very important. It's we deal with a lot of stigma in this field. It can be very difficult to talk about with other folks. People can feel guilty, they can feel shameful. There's a lot of hiding of use disorders, which we just need to get away from. It's no to me. Having an addictive disorder, whether it's alcohol use disorder, opioid use disorder, gambling disorder, gaming disorder, which is something we should talk about too, because that's something that is becoming more and more of an issue. Um,
Right.
it's no different than having any other chronic disease, I would argue. We don't chastise people for having hypertension, so why in the world are we chastising somebody that has an alcohol use disorder? The days of chastising are done. Now we need to identify it. We need to get folks into treatment that they can heal, and so we can get them to be functional again. And that's what I'm purposeful about, and that's what I hope to convey to anybody who listens to me.
I love that. Well, I'm glad you brought up stigma, and I noticed that you had mentioned you don't like to use the word rehab, and you replace that with a different term. What are some ways that we can identify terms? Because terms, our language can create stigma or continue the stigma. So, do you have some practical advice on ways that, as a provider, they can help reduce some of that stigma when they're talking to patients or coworkers?
For sure. Well, it's interesting. There are a few, and I apologize, I don't have the exact details of this, but a few years back, there was a study published in the Journal of Addiction Medicine, looking at the language that we use and how it relates to treatment time, so time and treatment for patients, and dropout rates. And interestingly enough, what they found by using some terminology that we would consider stigmatizing, it actually leads to decreased engagement. More folks drop out of treatment early, and more folks have behavioral issues when they're in treatment. So terms, like I said, rehab. That is one of the uh, terms that in that study that was considered stigmatizing. And even when I say it,
Mhm.
rehab, it just gives me a negative connotation. Um,
Mhm.
and so again, yeah, I'm very purposeful when I talk. Rehab is one of the ones that I substitute. I substitute residential facilities. I think it doesn't have that negative connotation that comes to mind. Even words like Suboxone, right? Suboxone can be very stigmatizing. So I really don't even may say Suboxone, explaining to patients the similarities between that and the true medication that's within Suboxone. Remember, Suboxone is a brand name, but buprenorphine is the actual medicine that does the job. And again, when I say that term, I don't get that negative connotation. But terms like addict, alcoholic, rehab, Suboxone, clean, dirty, all of these connotations, all of these terms can have negative connotations. And at the end of the day, I would argue anybody who treats this population, we want folks to stay in treatment as long as possible. It is a chronic illness, no different than any other chronic illness. So there needs to be some variation of treatment, really their entire lives. They don't have to be in a facility every day, their entire lives, but just the same as having hypertension. If you have a blood pressure issue, and you work with your primary care doctor and getting it to get it under control, you finally get it under control. Your primary care doctor doesn't say, "Okay, well, fixed. You've graduated. Best of luck to you. We'll never see you again." Because
Right.
if they do that, guess what happens? Their blood pressure will get out of control again. And it's very similar to all addictive disorders. There are differences in severity, and the more severe the disorder is, the more supervision and accountability we need to have on folks. But once they get stable, which most folks do, then that supervision and accountability can start to lessen to a place where they're in kind of a maintenance stage, where maybe they check in a couple times a year, or they check in once every 3 or 4 months at a program that has that purposeful curriculum. But yeah, we will always engage patients, and that would kind of be um, that I think is probably the best approach to dealing with this disorder.
Oh, wonderful. Thank you for that. Um, when we talk about medication or medicated assisted treatment,
Hmm.
you had mentioned that just Suboxone can have a stigma to it. And that is very true.
Yeah.
It does trigger people differently. You have people in recovery who take the 12-step approach, and then, it's an abstinence-based program. And then you have people who their physician and their care providers say, hey, this medicated assisted or medication assisted treatment is the path for you. But when you have those two types of individuals in a group together, let's say, and they're discussing, it can feel very different. And so there's sometimes um, this overarching stigma that medication assisted treatment is not recovery, or people, how would you address somebody who is in an abstinence based program?
Mhm.
What are some things for them to consider to start the idea of accepting medication assisted treatment?
Um, and this comes up a lot, actually. The way that I describe this is the way that I've described it for my entire career in addiction medicine. I like to think of recovery like winning a race, and there are a lot of roads to be able to win that race. You just have to pick the road that works the best for you. I think the biggest issue that folks come across is they tend to backtrack, right? So something comes up, an obstacle will come in that road, and instead of trying to find a different road or a way around that obstacle, they'll kind of just backtrack, either give up on recovery or actually move themselves backwards. That's the biggest issue. So, I always tell folks it doesn't matter which road folks take. They just have to take the road that works best for them. And for some folks, that will be an abstinence-based approach, and great, wonderful, good for them. And for some, that will be a medication approach or a different approach. I know folks that do none of the above. They'll I know a lot of folks who are in the fitness community and use fitness as their support mechanism. At the end of the day, it doesn't matter. I don't care how people win the race. I don't care which road people uh, use. They just have to pick one that works and keep making gains, and don't look back. Does that make sense?
Absolutely. Absolutely. It's kind of like you mentioned the GLP-1s, kind of a similar parallel to people, doing calorie restrictions and working out versus a GLP-1. It's two different pathways. Neither one of them are necessarily better than the other. It just depends on the individuals, what I hear you saying.
Yeah, yep, absolutely. And again, that's a great. I mean, with the GLP ones and looking that in terms of weight loss. There are so many chronic diseases that are linked to obesity, heart
Mhm.
disease, diabetes, other chronic diseases. Um, so dropping 10, 15, 20, 50 pounds, regardless of how you do it, is going to benefit not only the person, but also remember that healthcare does not have infinite resources. We have finite amount of resources, and if we can save a little bit of money for the system in general, well, then that helps us all. So again, I think that's a very good analogy that I also use for patients in, say, more abstinence-based programs that find it difficult to have conversations with folks who do take medicine.
Right. Thank you for that. I appreciate that. Um, as okay, so kind of going back to, let's focus on some nurses. We use the word self-care a lot, and I feel like sometimes people are growing numb to the term self-care. Yeah, I don't have time. Yeah, I've heard it. I've heard all the things. What is a way, you had mentioned health is so vital because our body is a machine, right? And we need to take care of it. What are some ways that we can reframe self-care or address it in a way that might be resonate to someone and they may not have heard it that way, right? Because nurses, they're burned out, they're overstaffed or understaffed, or excuse me, understaffed, or they, you know, still recovering from a loss that they experienced, all the different things that come into play, right? What are some ways that you might find it helpful to reframe self care in a way that maybe they haven't thought about it, or a more tangible, attainable, I can do this approach?
Well, I think nurses have the exact same problem that doctors do, where there's this, I would say, misguided attitude in our professions that the harder you work, the more you take on, the more you give, uh, the better of a provider that you are, better of a nurse, better doctor that you are. Um, I don't think that that's true. That has been shown overwhelmingly to lead to burnout, and it's one of the reasons we have such a devastating nursing shortage in this country, and same with the physician shortage. I would say boundaries. I've trained dozens of physicians. I've trained dozens of advanced practice providers. Um, and I always tell them the same thing, right? There needs to be a balance between what you do when you come to work and what you do when you leave work. I'm a big fan of saying to my folks, when you come to work, for me, when you're at work, I expect 100% of your skills, your time, and your effort. 100%. But when you leave, I expect zero. And that's how this should be. Um, I have 3 kids. I have a beautiful wife. Um, I am a competitive CrossFitter. Um, I don't, my world does not revolve around seeing patients all the time. But when I come to work, they get 100% of my effort. But when I leave, when I log off, when I hang up my stethoscope, um, well, then that's my time. And that's time that I need to keep myself healthy. And I need to focus on my family and keep them healthy. So my hope is that we can start to introduce boundaries in our profession as less of a stigmatized, less of a negative aspect. Boundaries are incredibly important to have. We just don't utilize them very well. And I'm happy to say that, a lot of things have changed. I've been a physician now for 15 years. And I remember very well having mentors in medical school and residency that were kind of that old school model where, um, always push, 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 push. It's all about work and never about yourself, although they never said that. But I'm happy to see now that things are changing. We do need to have balance in this life. We do need to give 100% effort when we're at work to our patients and to our colleagues. But when we're not working, we need to focus on ourselves and the rest of what makes us.
You know what? I love the way you reframe that. Thank you so much. Boundaries, I think, are a very important piece, and and practicing saying no, practicing setting those boundaries, I think, is very important for us to learn in all walks of life, with our children, with our coworkers, with
Yeah,
everybody. So
yeah.
I love. Thank you very much. I know we're coming up on our time frame. Is there anything, Mike, that you have, or Dr. Kirby? Is there anything that you may want to say to kind of tie up anything we've said? I know we only have a few minutes left.
Um, I mean, what I would say just in general, I love the nurses that I've worked with. Again, the nurses are to a doctor, nurses are the peanut butter to our jelly. And I've worked with some just amazing nurses, some nurses who have fallen in love with the field of addiction medicine. Um, there's not it's not a very widely known topic, but nurses can actually go on to achieve it's not necessarily board certification, but there's a certification in nursing that can show expertise in the field of addiction medicine, the certified addiction recovery nursing credential, and then the nurse practitioner also has their version of that as well, the CARN. Um, I've had 5 APP and nursing colleagues that have worked with me in the past who have gone on to get that credential. And I would just encourage any nurse or nurse practitioner who's interested in becoming an expert and really being a leader in the field of addiction medicine to take a look at that because we need more folks, especially nursing, who really know what they're doing and how to talk to folks with addictive disorders and compulsive behaviors. It's just it's an amazing resource to be able to have folks come in where they don't need to be trained from the very beginning. They have background knowledge and expertise that will they're able to just hit the ground running. And so If any of your guys' viewers or anybody across the country who's interested in more information on the CARN designation, I would highly encourage them to take a look at it. It's not very hard. I've actually written letters of recommendation for, like I said, 5 so far of folks that I've worked with. I think there's a set amount. I don't know all the details. There's a set amount of hours that folks have to spend working in addiction medicine in different levels of care, along with an exam and then letters of recommendation. But it's not unattainable, and I would highly suggest anybody who's interested to take a look at it.
No, thank you for that. Yeah, we just had an article not too long ago about as a way to prevent burnout, or as a way if nurses are considering leaving the field, maybe you just need to think outside the box, find something else that might interest you, a different section of nursing. So this sounds like a great option, and thank you for bringing that up. It's wonderful information.
Yep, absolutely.
That's great. Well, Dr. Kirby, I cannot thank you enough for taking your valuable time to be with us today, and hope to have you back in the future. I can't believe 30 minutes is already gone, but we're very grateful. And I didn't get to all the questions, so maybe we can have you back for that. But we really appreciate you and what you're doing, the work that you're doing, that is very powerful, and we appreciate you as well.
Well, thank you guys. I appreciate any opportunity that I can chat with you guys and share. I love addiction medicine. It'll be what I do until I hang up the stethoscope, and I just welcome any opportunity to talk about addiction medicine in a positive tone.
Wonderful. Thank you so much. Well, we'll be in touch soon, and hope you enjoy the rest of your day. Thanks for everybody who joined us today and listened to this. And if you have any questions for Dr. Kirby, please put it down in the comments, and we'll make sure to get those questions answered for you.
Thank you guys.
All right, thanks.
Thanks for listening. Don't forget to subscribe to this podcast and check out the Care for Nurses community space designed to provide support just for nurses. Visit carefornurses.com. See you next time.